Just wanted to speak to you briefly about some of the adverse events that occur in relation to drug administration. I think I've mentioned before to you that nurses can spend a huge amount of their working day or night administering medications or handling medications. So conservative estimates in terms of research have predicted something like 40%, but it could actually be a lot more. And as such, it is recognised that it is an area of a clinical practice that can be very problematic in terms of mistakes being made. I think if you've looked at any of the cases that we've been viewing as we go through the subject, you'll be quite aware of that. It's a complex task, there's a lot of knowledge, there's a lot of skill, and when we look at the fact that it's sometimes a very unstable, fluctuating environment, that we're doing this very, very focused task, you can see that mistakes are made. Again, if you think back to when we looked at the clinical incident, it's always when mistakes are made in relation to drug administration, it's usually from two main areas. It's something to do with the practitioner or nurse themselves, an individual factor, when it's to do with their knowledge, might be to do with their math skills, just their general knowledge in relation to and adherence to the standards for practice, and or over the arching that it might be a system situation where there's lack of staff and all the rest of it. So very complex area and lots of mistakes are made, and Staunton and Chiarella clearly highlight them into certain categories, if you like, things like the wrong drugs given, the wrong amount at the wrong time, it might be by the wrong route, we make lots of transcription errors, or that can occur, failure to recognise adverse drug reactions, and high-risk medications. So we'll just look at each of these in a little bit more depth. So wrong drug, when that's given, what can be some of the reasons for that? Well, if the drug order is unclear, if a verbal order is misheard, or failure to check the label on a drug, or simply misunderstanding that. So look at the case of Bhavesh Shah, HCCV Shah, lots of things there. The wrong amount, the wrong time, and the wrong route. Again, the wrong route is a major one because, again, that can come down to lack of knowledge, and there's been some instances of that, and I think Staunton highlights a couple of instances in the readings there. Just in terms of transcription errors, this is why there's been lots of examples. Again, it's been tightened up with electronic healthcare records and everything else, and sort of checking, but you never ever transcribe orders to other records. It's just an absolute no-no. Mistakes can be made, and there's always reliance on a secondary source. You only ever administer a drug from the original drug order sheet, and probably the best way, I'll give you a clear example of that. It comes from Wallace, and it's the Pillay versus Messiter case, and I might just sort of highlight that one for you. It was a particularly famous case, and it was back in 1989. A patient died from an overdose of Phenerton. The order for the drug had been transcribed from an out-of-date prescription sheet onto a new one. The patient had been ordered Phenerton 230 milligrams daily and Tegretol 1400 milligrams daily. What happened? In transcribing, the doctor wrote the new order as Phenerton 1400 milligrams to be given 3 times daily. A number of other doctors and nurses had also not noticed the error in transcription. That patient actually died as a result of that error, and the transcribing doctor was struck off the register for misconduct in a professional respect. So that's, again, never ever transcribe. Failure to recognise adverse drug reactions, well, that can come down to all health professionals, and it's one of your roles that when you administer medication, as well as knowing the correct route, time, all of those factors, there's an expectation that you are familiar with the common adverse drug reactions of any drug that you administer. Where do you get that knowledge? Well, lectures, textbooks, your MIMS, departmental circulars. It could be recorded in patient notes by the doctor. So very, very important. That's part of your role as well. Failure to recognise adverse drug reactions. And just finally, I want to just bring your attention to the high-risk medications policy. I'll just bring it over onto my slide. Now, you might remember that I spoke about this website when we covered the topic in clinical incidents, which is earlier in the session. And the CEC, remember, they are responsible for making recommendations when IMS reports are submitted. And that's the importance of reporting clearly when near misses or mistakes occur at work. They actually then gather data and then they can put out and make policies and recognise, for example, which medications are particularly risky. So they've actually got a whole section here on just medication safety and quality, and some good information into some of the high risk medications that have come across their path. So I'll just bring up the policy, which is, hang on. So here's the policy directive, high risk medicines in management policy. Again, I got this from it's on the New South Wales Health website, but I just again sort of linked it to the Clinical Excellence Commission and their role in recognising, you know, when mistakes occur and trying to minimise it. But for all nurses in particular who are involved with the practice of administering medicines, it's always really important to look at these sorts of useful information, I guess. Again, in your institutions, they should highlight this, but knowledge is power, I say. But there's certain ones, individual high-risk medicines. Of course, you've got your warfarin, your anticoagulants, hydromorphine, methotrexate, paracetamol, and potassium. So this is a good document, particularly to avail yourself of. So as well as the general policy on handling medications, you've also got those areas where essentially, if it's been reported here, warfarin, methotrexate, hydromorphine, potassium, they're all drugs that have been particularly risky, meaning they've harmed patients. Lots of clinical incidents have surrounded their administration, you know, and if you go through each of them, for example, anticoagulant, used extensively, they act through targeting, you know, they're very dangerous. And what sort of things, the errors that have occurred, duplication, use of a therapeutic dose when a prophylactic dose was intended, failure to adjust the dose, incorrect protocol use, incorrect use following discharge, and so on. So the Clinical Excellence Committee, they get notification, they amalgamate all that information, and that informs their policy. So just wanted to highlight that document for you while we're on the area of high risky drugs. Now, as I've said, there's lots of research that has gone into looking at why errors occur, and the research has come up with a number. It's again a complex area. There's a number of key factors. Nothing's a single cause. It can do with the individual, to do with the environment or the system, but generally speaking, and I'll point you to the O'Shea reading, which is contained in this module, but certain things have certainly come to the fore, and things like O'Shea, for example, points out that poor mathematical skills in individual nurses can contribute to increasing errors, particularly in particular specialty areas. For example, it might be aged care when dosages are different, and obviously paediatrics. Obviously, Hubble was another researcher and found that, like other health professionals, paramedics' medication calculation skills were found to be at times lacking. particularly for that particular discipline, problems for paramedics are they work in isolation, errors can go unnoticed, they might be reluctant to ask for help from a partner when calculating doses, and so on. So I guess mistakes occur in very specialist areas. There's always high risk. Comes down to individual aspects, knowledge of medications. The variables that affect level of knowledge include the length of your experience as a nurse and the level and recency of your professional education, obviously. And interestingly, studies have shown that experienced nurses tend to have greater confidence in their ability, but that doesn't necessarily mean that they demonstrate greater ability. In fact, Walters found that new nurses are more likely to report errors as against someone who's more experienced who might hide the fact or know the the ADRs and think if they can get away with it. So that's interesting. Lots of things like obviously the length of roster, workload issues, days, whether you're on days, nights or evenings, and obviously, for example, day shift, there's a high correlation with the number of drug errors on day shift because it's such a busy time, and there's a risk of interruption and so forth. So lots of things like that. That's why policies and procedures, many drug errors arise as a failure to follow policy, and that's why I keep stressing the importance not taking shortcuts, because that's when mistakes occur. Things like distractions and interruptions depends on the nature of the clinical setting, where there's a rapid turnover and rapid changes in patient condition. Drugs are often administered in chaotic settings, and sometimes the context doesn't lend itself to applying the necessary concentration. So, yes, it's quite a fraught area. So have a little bit of knowledge about that. And of course, criminal and professional issues in relation to drug administrations. Unfortunately, health professionals can and do have personal drug addiction problems, and I've linked you to a couple of examples in the module. There's lots and lots of examples from the tribunals in the hearings that we've heard, a lot of cases of professional misconduct, misappropriation of drugs. It's a sad fact, but there's easy access, and if you've got an impaired nurse with a coexisting drug problem, well, there you go. Easy access to drugs of addiction. Using drugs yourself or supplying to others is obviously a criminal offence as well. If convicted of an offence such as this, you will obviously face charge of professional misconduct, and because it's a safety issue perhaps, then you might face deregistration, various periods of time. Lots of cases of criminal negligence. Again, they're fairly rare, but in 1994 there was a very infamous case in New South Wales in Westmead Intensive Care Unit. A nurse injected Dilantin oral suspension into a central line instead of down the nasogastric tube. The patient had a cardiac arrest and died. Now, in that case, the nurse was originally charged with manslaughter because it was looked upon in the magistrate in the first, when it was first heard, thought, she was criminally negligent, but that was later overturned by a jury. But nonetheless, just when I say most cases are civil, but still that case served as a cautionary reminder that the stress for that nurse involved not only killing a patient but then being charged with manslaughter, which was subsequently overturned, but oh dear, very, very stressful indeed. So this area, very important. I'll again direct you to the Principles of Safe Medication Administration, which is in section 7.6 of that policy directive. And just in summary, drug administration is a major component of the nursing role. understanding of legislation, policy and procedure, it's imperative. Working within your scope of practice, very, very important. Remember, as a nursing student, I always make the cautionary note that if you're an enrolled nurse and you are through your enrolled nurse work administering medications, be very careful when you're on workplace learning as a nursing student and the BN to be careful here in adhering to your scope, not working outside that scope. And knowledge of your meds, storage, it's a developmental process and you've got to have ongoing education. All right, so there you go, just some references for you. So thank you.